Hey everyone, welcome back to the channel. My name is Aryan Malik. I'm currently a nursing student. This is Study with Me series. Today is day 24. We'll be continuing our discussion on fundamentals of nursing and we'll be talking about pressure injuries. Pressure injuries are also called pressure ulcers or bed sores. It's basically the skin breaking down from long term periods of immobility. They result from damage to skin or underlying tissues over a bony prominence. It is very common for bedridden clients who are not turned adequately or frequently, or it's also very common in clients with who have medical devices like nasal cannula or an oxygen venturi mask. They can also develop pressure ulcers due to intense or prolonged pressure, like long term use. Bed sores mainly result from bony prominence, so they are very specific to bony prominence. And bony prominence are basically areas that feel bony. For example, the scapula of the shoulder or the hip area, those are the bony prominences. So what are some most common areas wherein we encounter pressure injuries in our body? It's the lower back and buttocks, including sacrum and coccyx. It's also the heels and ankles, the hip bones, and the risk factors are also there. High risk for shoulder area, scapula, or the elbows are high risk. So any kind of body part which has like the bones protruding, or you're able to feel the bone in that area, um, it's very likely that if precautions are not taken for certain clients, that it can lead to pressure ulcers. Now let's look at the causes and risk factors for pressure ulcers. So the skin is breaking down from all that pressure as well as other factors that can make skin weak. Let's look at what are some of them. So for example, bedridden clients who are immobile from either neuro issues, spinal injuries, or just intubated and sedated. So being in bed for long periods of time degrades the skin. Another risk factor is incontinence or having wet bed. So clients can't some there are some clients who can't keep urine in with incontinence, hence it leads to wet skin, and wet skin is more likely leading to skin breakdown. It Another factor is also poor nutrition. The client is not getting enough proteins and their fluid intake is low, so they are at high risk for skin breakdown. Since there is no protein and fluid, there is a lacking of building blocks that are needed to maintain a healthy skin. Next is diabetic neuropathy, which causes lack of sensation with diabetic patients, and here we have lack of skin perfusion due to thick syrupy blood, and we usually in patients with diabetic neuropathy we see ulcers in the foot area, so foot ulcers which are very common. Next is liver cirrhosis. In this, the clients have low albumin. So, albumin is basically a protein that attracts fluid back into the vascular spaces, and if there is a decrease in the level of albumin or it's absent, there is a fluid which gets deposited. There's a bunch of fluid, hence which leads to edema, and we are back to having a water bed skin, and hence a risk for skin breakdown. Now let's look at different stages of pressure injuries. There are six. Stage 1, the skin is red and it is intact. It Stage 1 only affects the epidermis. Epidermis is the outermost layer of the skin. So the way to remember is the stage 1 only affects layer 1. So 1 for 1. The next is stage also about stage 1. It is non-blankable, meaning it does not turn white when pressed on. It stays red. If it is blankable or it turns white when you press it, it is not a pressure injury yet. It is soon, it may soon become one, but it is not as of now. Then the stage 2 is where the skin starts to break. It becomes an open wound. It is just starting to affect the top two layers of the skin, epidermis and the dermis. And here the wound bed is red or pink and shiny or dry. And again, the way to remember this is the stage 2 affects the top two layers of the skin. Stage 3, here it is more severe. The full Here we have the full thickness of skin, skin thickness loss, and it starts to extend into the subcutaneous fatty tissue, or which is the third layer of the skin. And here sometimes a wound might be tunneled under the edges of the wound bed. Again, the way to remember is this: three layers of the skin are damaged in stage 3. Now, stage 4, it's the most extreme of all. It extends all the way into muscle, bone, or even tendon. Four layers are involved, hence stage 4. Now, next is not stage 5, but it is unstageable. Here there is a full skin thickness loss with eschar. It's basically a deposit of black brown dead necrotic tissue on the skin, and slug, which is yellow and stringy. It's basically a rubbery substance that looks like a chicken skin. Since there are two colors describing the visualization or the appearance, this stage is characterized as unstageable. These wounds need to be cleaned out or typically need to be cleaned out or debrided, so that the wound bed can be visualized before a stage is made. So now, for instance, a nurse is assessing the skin of an immobile client. The skin covering the sacrum appears to have full thickness loss, but the wound base is covered in black eschar. How should the nurse document this finding? Unstageable pressure ulcer. Now, the next stage is deep tissue. It is dark, purple, and open. The fatty tissue is injured below the skin. Now, let's look at some treatment options. First, for bedridden clients, we assess skin and document it within the first 24 hours of admission. If not assessed and documented within the first 24 hours, hospital resumes the responsibility of the wound. So it is always a priority as soon as a client is admitted to have a full head to toe and skin assessment to make sure they don't have any pressure injuries or ulcer. If there is one, then you should click the picture, document it, and you should also characterize it which stage it is, so that because if it is found after 24 hours of admission, the hospital will be liable and it will be considered that this wound happened on the hospital premises. And also, it is really important to turn the client every 1 to 2 hours to relieve pressure on the bony prominences. Now, say the nurse is teaching a client with a stage 1 pressure injury on the greater trochanter of the left hip. What should be included in the teaching? Change position every hour. The next important term which comes for treatment is nutrition, mainly including protein and fluids. Fluids should be anywhere between 2 to 3 liters every day. What it does, it helps to build and maintain healthy tissues. And how do we as registered nurses know if the client has adequate fluid? We monitor the urine output. If the urine output is 30 ml or low per hour, then it means that there is a kidney distress or we have less than adequate hydration. Now say which finding contributes to delayed wound healing in a client with a stage 3 pressure injury. A client who has urine output of 25 ml per hour. Now when it comes to treatment, the next important term to remember is albumin, and the normal level for albumin is 3.5 to 5.0. If you remember from earlier, albumin it attracts fluid back into vascular spaces to prevent edema or waterbed looking skin, and it also helps the body maintain healthy tissue. So remember, the albumin level should be between 3.5 to 5.0. If it is not, the client is at risk for developing pressure injuries. Lastly, one should monitor for any pressure ulcer, the stage, size, or the color of it. And we use something called Braden scale. It is a scale which is used to monitor risk factors for skin or pressure injuries, and it is done by a registered nurse every shift. The way to remember it is BS, so Braden scale monitors risk factors for broken skin. So Braden scale, broken skin. That marks the end of this section. I hope you found this video helpful. Please stay tuned for more videos that will be coming out in the future. Thanks for watching.